suggest we do is it just so happened that our first item on the agenda, an update from 1-800 My Options, they're not available. And what we thought we would do would be a modified version of a bit of a catch up about what people are doing around the state. And, you know, for example, Anita, I know you sent me an email today telling me what you're doing, how you're changing things. So that would be really useful for people to know what you're doing. You know, that sort of thing, what's happening. And then I can do the presentation about the Senate inquiry that I thought people might be interested in, and that'll get recorded, and those people who we failed to connect with can listen to it later online. Does that sound reasonable? Angie's left her chair in disgust, an empty chair there. Well, shall I start? I think I'll start. Oh. And we'll still wrap up by 7, everyone, okay? So I would like to start by an acknowledgement of the traditional owners and a welcome to country. I'd like to acknowledge that this event that we are now publishing from takes place on Wurundjeri and Burrawang people country. We pay our respects to the Wurundjeri and Burrawang people, elders past, present and emerging, and extend that respect to any First Nations people who are present this evening. We also acknowledge that Aboriginal sovereignty has not been ceded and that Aboriginal people remain strong in their enduring connection to land and culture. And we've got Kylie. Oh, people are coming in now. That's great. That's great. So let's maybe start with a little bit of an intro. I think this might be the first time. Well, I know it's the first time Bianca's joined us, and I think it might be the first time Ben Rutten's joined us. Any other first timers? Kylie. Yes, Kylie. Yeah. So, not wanting to, you know, single anyone out, but Kylie, could you introduce you?
My name's Kylie, and I am a nurse at the Aboriginal Health Service that's in Albury.
Oh, fantastic, Kylie.
Yeah.
And I just keep repeating myself and apologize for tonight, but this has really never happened before. And usually we have a very efficient 1-hour meeting. So please come again. Delighted to have you. Ben, would you like to tell people who you are? I know who you are, but if you could let everybody know who you are.
Did you say me, Patty? It's Ben. Yep.
Yeah, Ben. Yeah.
Sorry about my lack of video. I'm just in transit, had an unexpectedly late finish at work, but I'm one of the O&G trainees at the Royal Women's Hospital, but also with a connection with Bendigo Hospital and the services there, and hoping to learn as much as I can from Patty and the team during my time at the Women's before hopefully returning to the country.
Great, great. Yeah, and Ben's an example of young trainees now are really interested in this work and then go on to embed it in their generalist practice, which is great. Is Lara? Yeah. Lara, would you like to say hello?
I'm Lara. I'm a GP obstetrician over in Echuca. I've come, kind of here and there before. I'm actually moving to Canberra, but I'm training up my delightful registrar, Arlie, to make sure that there's going to still be services in Echuca.
Oh, great. Now, Lara, we've heard from you before, haven't we?
Yes. Yeah.
You've been here before. Yeah. And so, yes. And look, before you go, send me an email because my dear friend is coordinating a lot of the hospital services in Canberra.
Martina?
Danica Vress.
Oh, all right.
Yes.
I'm getting contacts on contacts. So, yeah, that sounds good. Actually, I've specifically I'm going to Queanbeyan, but they've already tried to set me up with the Marie Stopes over in Canberra too. So, yeah, it's delightfully.
Your younger colleague to join in as well. That would be great.
Yeah. I'm just sending him a message now, so we'll get Gnarly in a minute.
Oh, great. And Bianca, we had a brief introduction before others came on. Would you like to tell people where you're from and a little bit?
So Thanks. I'm Bianca. I'm a GP out in Wadawurrung country. So I'm out in Geelong area, and I lead a community, a kind of a big community of practice, a GP education series that really came out of the pandemic and COVID. And we've been running now 3.5 years, really similar format by the sounds of things, Patty, to this, where we set up an agenda. We'll do a brief didactic. We run it on Echo platform, so we do case discussions, but we try to use those case discussions to bring to light service issues that then we try to find a way to seek solutions for. So I'm probably here because I linked in with I recognise that early medical abortion's a real problem in our region, and we've got what I guess has been termed as an abortion desert up in the Wimmera. So we'll be using this opportunity over the next 6 months as we teach about early medical abortion to also think about system solutions to I guess what's framed up as rural equity for women in our region, and trying to think about how we can bridge some gaps that we've identified through our data mapping exercise. So yeah, nice to be here tonight, and look forward to hearing more about what your group's up to, and hoping I can kind of link our GPs in as part of it.
Fantastic. It's fantastic.
And Bianca, are you aware of some of the resources that are available on the women's website around early medical abortion?
Look, just starting as part of our approach, like I said, it's kind of like, you start by trying to identify that this is a problem that we need to address in our region. Then we'll kind of look at what we try to synthesize all the kind of resources, from the evidence to the resources to the data to the. So where I'm up to is I've kind of we've been able to pull together the data and understand the problem from a data perspective, work out who's who, what resources are there, where are the knowledge gaps, what are the things we need to push. So kind of it's part of like the cycle, and we're not quite up to that bit yet. But what I have linked in with Shannon Hill is Women's Health Grampians. She's been, I think you guys are working with her at the moment around some access projects, and I think there's a similar crew out in Barwon Southwest. So I'm expecting they'll link me in with everything that you guys have been doing. I noticed Shannon's part of this group as well.
And been a star. Yeah.
Yeah, great.
Fantastic.
Well,
Yeah. I look
And
forward to contact.
welcome to
Thanks.
yourself and the projects. And
Thanks.
I'm seeing 2 other new faces. Ali, would you like to introduce yourself and tell us where you were?
Hi everyone, my name's Ali. I'm one of the GPO registrars in Echuca.
Oh,
Oh, great.
oh, Lara was just talking about you, I think.
Yeah, that's my reg.
That's
And,
Reg. And so you're the heir apparent, we've heard.
Apparently, yes.
Well,
I'll be filling the fort in Echuca.
yeah, a very warm welcome to you. And Tim, I see Tim Osekas. Tim, would you like to introduce yourself? Hi.
Hi everyone. Yeah, Tim O'Seeks is my name. I'm a registered nurse. Been working for Mara Stopes in Eastern Kilda for the last 2 years, mainly in theatre and PACU. That was for 20 years before that, I was working as a mental health nurse. So it's been a bit of a transition for me. So still fairly early days in the sector.
You just got off. You just gone mute.
Can you hear me now?
Yeah, that last sentence we just missed. Sorry, Tim.
Oh, okay. So yeah, I've been working in the sexual reproductive health area now for about 2 years after previously working as a mental health nurse.
Well, that's fantastic, that because you'll bring all of that to your work at the moment. So I think this is the first meeting of us you've attended. Is that right?
Yeah, it is. It is. I just found out about the group a few months back.
Oh, great.
Thanks for having me.
And are there any other people who this is the first time they've attended? I'm just pointing to somebody. Karen, have you been here before?
Can always introduce themselves
Yeah.
in chat as well.
Yeah, or send a message in chat. Yes.
Hi there. I don't think I've been to the meetings. I've been to some of your webinars and things, but don't know if I've been to these meetings particularly.
And great. And where are you working? Sorry.
Oh, okay. I'm a GP, and one of my jobs is at the Fremantle Women's Health Centre, where we provide medical terminations of pregnancy as well as all forms of contraception.
Oh, fantastic. Did anybody want to share anything new that's happened in their area, or any change in their practice or their referral pathways, or anything they wanted to share with the group at all?
Well, I'll just say for Peninsula Health, we've just come up to 18 months that we've been providing medication abortion.
Yeah.
So that's really good. It's a very consistent service.
Yeah.
We've still got just the one clinic on the Tuesday afternoon, and occasionally we have too many referrals or too many most of it's self-referral. But we've seen a little increase in GPs who are providing in the area for MTOP as well, and can very easily refer off to one of those GPs if we're unable to fit in, which is really good. And we've also exceeded, done more than 500 IUDs now in the service that Kathy and Robin had started, and of course then I've come on board. So we've hit a few milestones. So what is my service type? Oh, where I am at Peninsula Health in Victoria. There was just a question in the chat about.
So is that a community health service?
It's a community health service. Yeah.
Thanks.
They're one of the funded hubs.
Oh, you're a hub, right? Gotcha. Thanks.
Angie, would you say that your demand has gone up, or has it gone up and plateauing?
I think it grew and then it plateaued. I think what was unexpected was that half of the contacts, I'm just saying approximately, that we get are actually women who need a surgical or wanting a surgical service. So a lot of half of our work is doing bloods, ultrasounds, and referring on.
Yeah.
And we're noticing that big, like everybody, that big gap in lack of surgical public service.
Yeah.
Yeah.
Well, it's fantastic to have that data and those stats of resilience, and growth. Yeah. Anita, you had sent me an email just very recently about just a change to where you're going to be consulting. Do you want to share that with the group?
Yes. Hi, I know some of you, Angie, Tim. Oh, I can't see everybody on my phone. Sorry. Kathy, there's a few people I know. So I've started a private service called Sexual Health Options in Frankston, Victoria. I operate, sorry, can you hear me?
Yes.
Yes. I'm operating out of I'm renting space in a GP super clinic, which is at 89 Young Street. We have a corridor in there, and I have an ultrasound machine. So I've been a surgical termination provider for about 8 years, and have worked at Murray Stopes and Hampton Park doing surgicals and medicals. So I am proficient in ultrasound. I have an ultrasound machine. We have pharmacy and pathology on site at where Sexual Health Options is. So, and because I'm a GP obs, patients can come in. They don't need a referral from a doctor. I can date the pregnancy and give them a script for, well, we can have the medication actually brought to us to the clinic if they want to take the first dose at the time of the appointment, and I talk them through that. So it's a little bit unique. I only have been operating or practicing there for 8 months, 9 months, and it's very quiet. And for the next couple of months, we are going to offer healthcare card holders a bulk billed service with a $25 booking fee. So that's because people seem to book at multiple sites at Hampton Park and Murray Stopes, but they don't cancel. So then that's holding an appointment that someone else would miss out on. So if that's for telehealth as well as face-to-face. Happy to take questions.
That's great. I'll just comment because I know you, Anita. There need to be the GPs that we will refer onto, like for if we've got overflow in our clinic. So that's really good to hear your update. And it's great having you there. It's good.
Thank you. Yes, there's a question. Yes, absolutely. I did a telehealth this evening with a woman in the Atherton Tableland. So I'm able to send her an e-script. We had spoken to her in the last few days around finding a pharmacist who would dispense and talked her through that not everybody does. And yeah, my reception staff, I have to say, fantastic. So they're able to provide the women with some information around what to expect in this journey.
Thanks. Any other questions or comments? Look, I'm just really cognizant of the fact that we always want to schedule this as a 1-hour meeting and not take up too much of everybody's time. So I think we'll progress now to the little presentation about the recent Senate inquiry that quite a lot of us have been involved in, because I thought people just might be a little bit interested in the way a Senate inquiry plays out. And while Kath is setting it up, just to share from. Yeah.
Everyone see that? Right.
So look, I just want to make a statement that I have got a post-viral cough and I'm not in any way infected. And I know that Kath is not frightened of me, even though she's backing away. But it is annoying for everybody, and the evenings are particularly difficult. So I am sorry if I punctuate this with a lack of fluency. So the reason I wanted to share this was Kath and I were just talking a little bit about, you know, the recent experience and what we had learned from it and what we reflected from it. And it occurred to me that I knew nothing about Senate inquiries until I was asked to write a submission. And I had no concept of how that might fit in with a piece of advocacy work. And we're a community of practice here online tonight, but we're also living, breathing, staunch advocates for women's health. And so it's with that sort of advocacy side of things that I thought you might be interested just to hear a little bit, and then maybe to ask some questions, or we might have some reflections at the end. So I'm sure all of you are aware that there was a recent Senate inquiry into sexual and reproductive health care across Australia, and that reported late in May. The background to that was that it was initiated by the Australian Greens late in 2022. The first thing about a Senate inquiry that I have learned is that it's an opportunity for advocacy. If you find that there is an inquiry in your area of health where you can place submissions. And it's important to understand where that inquiry is coming from, who's initiated it, and what the rationale is behind it before you decide whether you're going to interact with it. Because they're not neutral, and they are a political structure about investigating a potential legislative change. So the background to it is that in 2022, there was general response in Australia to events in USA with the reversal of Roe versus Wade. And you might remember that the initial response, maybe in the media and maybe amongst ourselves, is thank God that's not here. Isn't that terrible what's happening over there? Thank goodness we've got good laws, etc. What came secondary to that was a bit more of a community dialogue with media interest along the lines of, hang on a minute, how good is it in Australia? And it really became a moment for us to increase our advocacy and push the agenda about equity of access to both contraception and abortion care and to other issues in sexual and reproductive health. So the inquiry was initiated late in 22 by the Australian Greens, and how they initiated it was to look into the provision of the National Women's Health Strategy. Now, the National Women's Health Strategy was developed in 2018, 2019, and initiated to start in 2020 and be rolled out by 2030. So there was actually a benchmark to analyze. And it really was a throwing down the gauntlet and saying, look, we're 3 years in, what have you achieved? And in light of Roe versus Wade, what should the response be? Submissions were to be put in by December 2020, and initially the report was to be by March. It was extended 2 times because of the sheer volume of reportage and the need to increase the number of public hearings that they had. Over on the right of the screen are the terms of reference. Now, I'm not going to go through all of that, but it's to show you that it was really very broad. So it didn't just include the title for the Senate inquiry, which was stopping the postcode lottery for sexual and reproductive health. It also included and invited comments on equity of access to maternity services and to fertility services, and also specifically invited comments and submissions with regard to how we were delivering services to vulnerable and marginalized groups, and how we were training our workforce. So there was really quite a large terms of reference, larger than most Senate inquiries. On the right here, I'm showing you a screenshot from the website, and I really want to encourage you to look at the website. There's a drop-down box where you can look into the inquiry homepage. You can look into the terms of references. You can read each and every submission. You can look at the media releases. You can see where the public hearings occurred. You can go into the public hearings and find out who presented at each hearing and what their submission had been originally. And then you can look into the Hansard and read exactly what was said and what questions were asked. And then there are some additional documents that some people presented. And then there's the final report. And I'll just let you know, it runs to 179 pages, the final report. So don't download it. I pressed print. Don't do that. You don't need to. But it's a very interesting way to look at how good governance could work in a democratic society. And I've really enjoyed looking into this to explain it to you tonight, because I've actually now read every submission. So I read some of them before I went to present, and now I've read them all. And it's very interesting. There were 352 separate submissions, and they were made by individuals and organizations. Note was made by the Senate committee that there were 4 separate campaigns running with form letters or duplicate letters sent by different people. They provided a sample of each of these, but they did not include them all. So when we talk about 352 submissions, within that, some of the campaigns are self-explanatory. Cherish Life is a group that are anti-abortion, and they had a form letter which basically challenged the terms of reference of the Senate inquiry, challenging that abortion was necessary at all, or indeed a moral good in any form, or that contraception was. And each and every letter was exactly the same. So they provided an example of that, but they did not count in their submissions the 2,000 identical letters. There's another group called Third Party who did a similar thing. There's a group called Surrogacy Australia that put in 20 of the same submission about access to IVF. So they were acknowledged, but they weren't put to the total. And the interesting thing about that is that we have learned from that you can't flood a Senate inquiry with form letters and just everybody writing the same thing. It's not a get up campaign where you all just throw everything, throw the same thing and just sign it. they're aware of the difference, and what they were really looking for was nuanced submissions that shed light on the issues that came up with some suggestions. And where I would agree with something that was said by the anti-abortionist campaigns was that they said that the assumption from the Senate inquiry was that abortion and contraception was a healthcare issue and that it was seen as a healthcare right for women, and they took issue with that. Now, I would agree with them that that is the assumption of the Senate inquiry, because it is legal to have those services in Australia. So I would completely agree with them, but they've gone off on a tangent about turning it back into an argument about abortion. So it was quite appropriate that those submissions didn't become part of the major part of the Senate inquiry. So that's an interesting thing to learn. The majority addressed sexual health, not sexual health, sorry, and particularly the provision of abortion and contraception. So the vast majority, it was over 80%, were really from our industry, if you like. A minority addressed, again, equity of access issues. So everybody was really addressing that, but to fertility and maternity services. So submissions about birthing on country, about lack of maternity services in regional and remote Australia, about the inability of gay couples to access Medicare if there was going to be a surrogate use. So it was basically the same thing, equity of access, but a small minority of the submissions, and a very, very small minority addressed all of the terms of reference. You didn't have to, but some people did, or some associations did. But I really encourage you to have a little look at it. One of the things that impressed me on an emotional level was how many people put in submissions that included their lived experience. And I find that a very, yeah, it was emotional reading quite a lot of the stuff. And I know that 2 patients with lived experience actually did present at one of the community consultations. And it was a very brave thing to do. The themes that were presented, I've called them really AAA, just to remind me, they were really about access, affordability, and appropriateness of contraception and abortion care and the services that we provide. And there was incredible consistency across the submissions. Really, the key thing that most groups were identifying was a lack of access to affordable contraception. And then the corollary of that was they would be advocating for free or affordable contraception, information and provision. And the focus was on the role of the TGA and the PBS and Medicare. And people consistently focused on those, and standing back from it, I think that was entirely appropriate, because those are the federal issues that could be changed to make a difference. And this was a federal government inquiry. It wasn't a Victorian inquiry. There's been an ACT inquiry happening in parallel to this. This was across the nation. And as the same as their submissions with regard to contraception, the same issues came up with abortion care. And it was that early medical abortion should either be free or affordable and deregulated. So there was an agreement across everyone that put in a submission about this to deregulate it. And I would summarize that as a concept that early medical abortion is a drug like any other and shouldn't be over-regulated and artificial barriers created towards the patients. There was an agreement that there should be public provision of abortion, so public hospital provision of abortion, and aftercare provided in public hospitals for post-EMA. The public hearings were grouped into interest groups, and we're by invitation only. And if you click on each and every one of them, it tells you who was there. I had the honor of presenting in a session where the Pharmacy Guild and culturally and linguistically diverse patients groups also presented. And the same afternoon, the TGA presented, 1-800 My Options presented, Women's Health Victoria, and 2 patients with lived experiences. So it was a very interesting afternoon. They invited you to make a brief statement, which was not to be a repetition of your submission. So just to give you an idea, submissions varied from a couple of angry and pointed paragraphs to 20 to 50 pages. So they didn't want you to repeat it. You had 2 minutes to give a summary and to state which institution you were representing, if you were representing a group or institution. And they were genuinely looking for solutions. So a lot of the inquiry after the 2-minute spiel that we gave was, you know, what would you suggest are the key things? So they were really wanting us to go into the inquiry with a thinking hat on, not just describe the barriers. You can download on this part of the website, you can download the program and the submissions, or at the end of the report, there is a list of who attended. I noticed that none of the anti-abortion representation attended, and I can see their rationale for that, which they explain. With regard to the report and recommendations and where to from here, there were 36 recommendations in total. And I must admit, I was sort of falsely excited when I read them the first time around. I thought, this is great. And then I read them again, and look, about half of them didn't mean much to me as a practitioner. I didn't see them being translated. They tended to be very general or mission statements rather than specific. However, there was some really good stuff in there. And the categories were around COCP provision, affordable for all, IUD provision, affordable for all, abortion access provision, equitable and affordable, and a group on linked together about improved service delivery for vulnerable marginalized groups, First Nations, CALD, LGBTQI, disability groups, focusing on getting the services right and appropriate. So again, one of the A's, accessible, appropriate, and affordable. There was really general bipartisan consensus on it, and there was an agreement that there should be public hospital provision of services, but where there was disagreement, and I think this is really important, is around the topic of whether it should be free versus affordable. And this was really along party lines about the concept of whether there should be some form of user pays for contraception and abortion care, and versus it being available completely freely. And so there were arguments back and forward between the committee about why should it be different from other health services. It generated a lot of really good media coverage. I'm just showing one of the many media releases afterwards. Senate inquiry to call for improved abortion access at Australia's public hospitals, which I think was a really, really important part. And that is agreed on. And that is a national thing that could be done. Also agreement on the role of TGA at the PBS and Medicare. Also in that time, really supportive statements from national training and professional bodies, from the AMA, from the College of ONG, from the College of Midwifery, from a great many groups. The summary statement is basically an agreement that they all agreed about the 36 recommendations. But if you read the additional comments by the ALP and the LP, there's additional comments from the Australian Greens. explaining that there was a complete and utter failure of disagreement around the concept of free sanitary provision of sanitary items for women with menstrual poverty, and that there was complete disagreement around the concept of absolute free contraception or free no cost, no out-of-pocket cost for abortion care. And significantly, the comments by both the ALP and the LP are that, yes, they agree with the above. And rather than celebrating that there were a lot of things that could be done nationally, they flipped it round and said, most of these, however, are at the level at which states would be, should be responsible for carrying them out. Things like training and provision, which actually is wrong, I think, having read it, that the TGA, the PBS, Medicare, national training provision, national bodies for training, those are all national things. But I thought that was really significant. And so what do we do now as advocates? And so there has to now be a stage of an advocacy response, because that could just get reported. And then there could be some argy-bargy, as I think some of you from the sidelines in healthcare have already seen, cost shifting all the time between federal and state. Who should take the responsibility for hospital provision? Who should take the responsibility for funding? What has come about, and I really still think this was the usefulness of being involved in the whole Senate inquiry process, was that we have increased our advocacy profile with the Department of Health federally and with the Department of Health in our state. And they now want to develop a list of deliverables, because they're not going to be able to deliver on the 36 mission statements. So they did actually approach us very recently to nominate our key recommendations. And the key recommendations that we have suggested should be really important, and then also offered ourselves as being willing to provide some of them, are that based around the two main ones that focused on the TGA and the PBS role to deregulate EMA and ensure best contraceptive methods available and affordable. So things like getting copper IUDs onto the PBS. There were lots of little things that they really should have put them all together and just said LARCs or EMA, deregulate, make it cheap, make it available. The Greens have said they want to change the recommendation to make it free. There will be a very fiercely fought battle around that. The second one that we really wanted to push was adequate practitioner remuneration. And the third is the mandating of public hospital provision of abortion and contraceptive services. And there are lots of other really good ones, like funding a national 1-800-MY options, which we also agree with as well, but we're only allowed to name 3. And the reason we mandated the final one was that we want to position ourselves as providing that service for other states at our hospital, if necessary. And to say that we've got a blueprint where we could be part of a easily deliverable increased training program. And we really got the impression from them that they were looking for that kind of leadership. So that's really what I had to say about it. And I'm still trying to work out the next steps beyond that. I'd be really interested in people's reflections, learnings, anyone who also took part or heard anything about it, or anybody who's got any concepts about what we should be doing as our next steps. But having stepped into that level of an advocacy arena, I'm aware that there's a lot of work to be done and a lot of lobbying to be done at that federal level if this very important Senate inquiry is not to lose ground. So at 7:05, I think we could go to 7:10. We could take some questions or comments.
Thank you. I mean, I feel like I'm a newbie, so I don't want to jump in, but I'll just quickly say thank you. It's really useful. Like, I think PHNs take on board, and it's a strategy of ours going forward in our region to advocate. So knowing kind of how I can be, you know, asking my executive team to advocate to federal is really good. So I look forward to continuing the conversations, because I guess I'm really at that place where we're trying to implement that workforce development, build the models of care that GPs, you know, might use, those nurse-led models. We're thinking about that at the moment. How do we, you know, work with that group to help them with whatever their identified needs are? So I guess that's where we could work at a federal level, but we currently don't get federal funding to do that work. So it's all, everything that PHNs do are based on project funding. So it has to be a project the federal government order us to do to be able to do it. Otherwise, it's a bit of a cobbling together exercise. But anyway, it's good to know that, I mean, that's kind of where what we'd need to get that piece of the work done. But also I think that I'm really pleased to hear about the service provision, because I know that a lot of the rural GPs won't provide medical abortion without surgical cover. So again, that's an interdependency across federal state lines, which we really appreciate. But yeah, thanks. So it's good to kind of keep knowing how I can help coach my PHN team to advocate to the feds.
Yeah. I guess the other thing I would say is that the actual process of getting involved saw us make some really good links. So other groups we'd contact other groups, we'd say to each other, do you want to give us just your top 3 or 4 things you're going to say, so that we can back each other up, so that they don't get a whole load of inconsistent or, you know, an enormous range of ideas. And I think that really, unlike a campaign letter, I think it really showed out. And the other thing, and I was just, I think it's Marianne has reminded me to announce, thank you, Marianne, that Castlemaine is going to provide a fortnightly stop service alternating with Bendigo stop service. Was that you, Marianne, that was telling us that? Yeah, and I'd heard that recently from Mark Farrugia, who'd asked me to share it tonight. Part of that has come from, and he shared this as well, his increasing enjoyment from being part of an advocacy group and the community of practice that he's built up. And the other group that have doubled their numbers and doubled the access to surgery is also a direct result of their advocacy. That's the Northern Hospital. They decided to put in their own submission, and as a result of that, they their chief medical officer read it, and they decided they would double their numbers. So, you know, some good has already, you know, come out of it. And I'm happy to share the presentation, of course. Yeah. I hope you find it interesting. I find it really interesting going back over the experience and then looking at how other people had approached it. And I think that was where the learning was for me. Does anyone else have anything they want to say before we close at 7:10? No, otherwise I'll say good night to you all, and we'll share that online.